Good morning, everyone. Thank you for joining us. This is the California Health and Human Service Agencies, or Cal HHS, Alzheimer's Disease and Related Conditions Advisory Committee meeting. Today is May 1st, the 1st of May, 2025, and this meeting runs from 10 a.m. to approximately 2 p.m. So we appreciate your being here with us. We are meeting both in person at the California Department of Aging's office in Sacramento, as well as virtually. And next slide, please. And I am Carol DeAndres. Thank you for joining us. I'm with the MPA team here at the California Department of Aging. And if we go to the next slide, here are some meeting logistics for you. If you're attending virtually, we have these links for you, as well as if you would like to join via audio. Number is 888-788-0099, and you would put in our webinar ID, which is 841-7002-0247. We have live captioning and American Sign Language interpreting. We thank Bailey and Rex for being with us to be our ASL interpreters. Thank you, guys. And following this meeting, you can find all of the documents, the PowerPoint slide, and recording posted on the Cal HHS Alzheimer's Disease and Related Conditions Advisory Committee webpage. Thank you. And I do want to remind folks to mute themselves. I'm going to go ahead just to reduce the background noises. Letting you know that the chat function is enabled for committee members, California Department of Aging staff, Cal HHS staff, and other invited guests to share out meeting resources and information. And you're able to view that and click on that and during the meeting. We invite the public to provide comments and hold those comments until the designated public comment period, which today on the agenda is approximately at 11:30 a.m. and again a second time at 1:15. But the Q&A is also enabled, so feel free to put in your question there, and the committee will either respond or we will take it back and get you back a response. As always, if you have any additional comments or questions following this committee, you may email the Engage email box. That is engage, ENGAGE, at aging.ca.gov. Next slide. Live captioning is available, and it is available through your Zoom webinar functions. You should have this icon, the CC show captions. You can enable that yourself. If for some reason on your toolbar it is not readily apparent, please hit that more button. It's a three dots more. It hopefully is hiding underneath there. So please enable that if you need that. Next slide. Again, if you would like to make public comment, we do have 2 public comment periods. If you're in person in the room, you can raise your hand and one of our staff members will call on you, give you your turn. For our verbal comments, use your raised hand icon via Zoom, and we'll call on you via that. And written comments, again, to engage, ENGAGE, at aging.ca.gov. We do want to note that public commenters will have 2 minutes each, just so that we make sure that we're able to have time to get to everyone who may want to leave a comment. Next slide. So, good morning, Dr. Caneo. I will spotlight you. Hold on 2 seconds. Good morning. Thank you for being here, and go ahead.
Good morning, everyone. Welcome to today's Alzheimer's Disease and Related Conditions Advisory Committee. I wanted to begin by thanking each of you for being here, whether you're joining us in person or virtually, and for the commitment you bring to this important work. And just a reminder for the committee members who are participating via Zoom, please have your camera on and let us know if there's a tech reason why you can't have your camera on per the Bagley-Keynes Act. Just a quick shout out to the Alzheimer's Los Angeles for being awarded American Society on Aging 2025 Health and Wellbeing Award. So kudos to Alzheimer's LA. And I think right now we should look at the agenda. Let's go to the next slide. So we have a pack agenda. We'll start with the navigating long-term services and supports and California's no wrong door policy, followed by committee update, California Department of Aging update, California Department of Public Health update, and legislative update. And then we will finalize recommendations as we usually do later this afternoon. Go ahead and go to the next slide. So before we get the attendance right now, we will review the February minutes. Each of you should have received the minutes via email. So any questions or comments about the minutes we had in February? No questions? Okay. Well, can I get a motion to approve the minutes?
I make a motion to approve the minute.
I think that was Barbara. Thank you. And the second, I think that was Dr. Mobley.
Right.
Great. Any further discussion? All right. All in favor say aye.
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 Sounds like we only have two people.
Aye. Aye.
Why don't we do any opposition? Any abstention? Okay. Well, the minutes are approved. We will do the roll call now. Let's put up the slides again. Probably should have done that first. I'll just call on the folks on the slide here. I'm Wynn Canio. I'm the behavioral health representative. Carlos, you want to say a few words?
Hello, I'm Carlos in Sacramento in person.
All right. Senator Araguin's representative.
Hello.
Yeah. There's a chief of staff meeting today at 11:30.
Okay.
I think we go.
Sally Bergman.
Good morning. Happy to be here.
Thank you. Claire Day.
Hi, good morning from Sacramento also.
Thank you for being there. Dr. Thompson.
She's not here today.
She's out, right? Okay. Myra.
Doesn't appear Myra's with us just yet.
Okay. Let's go ahead, go to the next slide. Here we have Ken.
It does not appear that Ken is with us either.
Okay, and I know Barbara's here.
Aye again.
Dr. Mobley.
Hi. Good morning on this May Day.
Dr. Kazi. Sorry if I mispronounced your name.
You have it correct. Good morning from Southern California.
Great. Celine.
Morning, everyone.
Julie.
Good morning.
Dr. Frias. Don't have her either, sounds like. Okay.
I believe that Dr. Gravano, are you in appearing on behalf of Dr. Farias, or am I misspeaking?
I have in the past. I was not specifically asked to today, and I hadn't planned on, but I am here as an alternate if that needs be.
Thank you. I'm clearly not a voting member, but just thanks for being here.
Yeah, thank you, Dr. Gravano. All right, I think that concludes our roll call. We will now move on to our topic of the morning, navigating long-term services and supports and California's no wrong door policy. Long-term services and supports provide essential daily assistance for individuals with cognitive decline and assist families manage caregiving responsibilities. Families often describe the system as confusing, disconnected, and difficult to assess. Although we know we have a lot of services out there that people can use. So hopefully with today's presentation, we can make this a bit more easier. And with that, we have Anna from the CDA, Carlos, our vice chair, that will talk about his caregiver experience. Mark Beckley from CDA will talk about the No Wrong Door updates and presentation. Brian Carter, Calls Connect presentation, and then Allison Bridging Aging, Disability, and Networks. So go ahead, Anna. Go ahead and take it away.
Thank you so much. I just want to check in. Can you guys hear me okay?
Yes, sounds good, Anna.
Excellent. So thank you so much, and really appreciate the committee interest in this particular issue around navigation and no wrong door. As you all know, in the work that you do, this is an issue that comes up time and time again around navigating services and supports for the individual, but also caregivers and family members. So I wanted to kind of start the conversation with just going over a little bit on the background on the Master Plan on Aging and connecting it specifically to navigation and no wrong door. So to start with, you're all familiar, I'm sure, with the 5 bold goals of the Master Plan on Aging. And goal 1 really being around housing and people, individuals being able to live where they choose as we age in the communities of choice that we have, and these communities being age friendly, disability friendly, and dementia friendly, as well as climate and disaster ready. Goal 2 is around Health Reimagined, focusing on access to the services that we need to live in our community of choice and to really optimize our health and well-being and quality of life. And then with Goal 3, we have that inclusion and equity, not isolation, which is really around our opportunities, right? To be able to work, volunteer, and really engage within the community, and to really reduce isolation, loneliness, abuse, neglect, and exploitation. And then Goal 4 being around caregiving that works, really looking to see how we prepare our direct care workforce, right? And to be able to support individuals as they age. And of course, this includes our both our family caregivers, right, which we have over almost 4 million family caregivers that help their parents, their spouses, their neighbors, their friends with everyday tasks to help them live in their home and community, as well as the paid workforce. And then, of course, Goal 5 is around affording aging, ensuring that individuals have economic security as they live their life. So we'll go to the next slide. And so a lot of the work that we're going to talk about today and kind of framing around navigation, no wrong door, is really within this context of the systems change framework that the Department of Aging has developed around long-term services and supports. And we really have these 4 pillars around systems change to improve access and availability, right, of the services and supports people with disabilities, older adults, need. And so this is all really centered around person-centered principles. We have this equity focus that we stay rooted in and really ensuring that we're data-driven in all that we do around long-term services and supports systems change. So these 4 pillars, we're really going to focus today's conversation a lot on navigation, right? How do we increase access and availability of services? But we know, and we're going to hear today from Carlos, we're going to hear from Mark, right, that people really have that difficulty with figuring out how to access services. Often you don't know what's out there. You don't even know that you need it until you find yourself in a situation where maybe you have a parent who is developing dementia or Alzheimer's, acquires a different disability, and suddenly you're thrust into this world that you've never known about, and it can be really complicated to navigate. So today we'll really focus a lot on that. But the second pillar is around access to the services that people need, ensuring that people are able to remain in their homes and avoid institutionalization. And that we know that while it's great to be able to navigate and find the resources that you need, we also need capacity within some of those services to be able to serve individuals. And we often hear of, certain programs that aren't in certain parts of the state. There might be long wait lists. And so the second kind of pillar around this is how do we create better access to the services? This could include housing. This can include behavioral health services for older adults to address loneliness and isolation. And one of the things we've been working on is our home and community-based services gap analysis that we're finalizing right now. We'll be releasing in June, and really then developing a roadmap of addressing those gaps. What can we do to address some of the gaps in long-term services and supports in California? The third pillar, which we'll actually speak to a little bit today, is going to be around workforce, ensuring that we have a workforce that will meet the needs of our aging population, and of course is a critical goal of the Master Plan on Aging. And finally is financing. How do people pay for and afford their long-term services and supports? Medi-Cal pays for much of our long-term services and supports, and we know that there are many individuals that are in the forgotten middle or missing middle that have a hard time paying for that. And so we are working on strategies around addressing services for that forgotten middle. So we'll move on to the next slide. So there are a few specific Master Plan on Aging initiatives we're going to go over quickly because you're going to hear more about them today. So one is around navigation, and this is around establishing a statutory framework for development of California's first ever statewide aging and disability no wrong door system. You're going to hear more about this from Mark in a little bit. We'll go to the next initiative, which is around strengthening the interagency disability and aging community of practice. This has been a collaboration across state departments between the Department of Aging, the Department of Developmental Services. You're going to hear from Allison today specifically on what we're doing to address the needs of older adults and people with disabilities across their lifespan, with a specific focus actually on how do we bridge aging and those with developmental disabilities and intellectual disabilities? So you hear more about that next coming up. The next one, we'll go to the next slide, is around workforce. So you're also going to hear about work that we're doing to really support that navigation piece for individuals who need access to services. So Mark will be going over the no wrong door piece, but you're going to hear about some of the work we're doing around community health workers, including our CALS Connect program. You'll hear from Brian on work specific to Alzheimer's and dementia and helping support people navigate the services and get connected to the resources that they need. So we'll go to the next slide. And with that, I actually want to really make sure that we're rooting this in person-centered, the individuals, right? Everything we're doing here is really about ensuring individuals, our community members, our family members are getting access to the services that they need and rooting in that personal experience. So Carlos, thank you for taking the time to share some of your own personal story with navigating access to services as a caregiver and with your family members. So with that, I'll turn it over to Carlos.
We have audio. Try it again, Carlos.
Okay, can you hear me?
Can hear you. Thank you. Sounds good.
Can you see me?
And can see you. You look great. Thank you.
All right. Rename me. Okay.
You're going to have a CDA background.
Okay. So for many people on the call that don't know me, my name is Carlos Olivas. I am a family caregiver, and I care for my dad living with Alzheimer's dementia. Navigating services has been very difficult for me, especially in the beginning. 2015, I received a phone call from my dad's dentist explaining that they had concerns about my dad's health. Their observations forced us to seek out connection with my dad's primary care physician. My dad had an appointment. My brother flew in from North Carolina, took him, and explained the concerns. He was diagnosed with mild cognitive impairment and prescribed some medications. And then that was it. There was no follow-up or next steps to kind of navigate us on what to do. I ended up moving back home, start caring for dad. I didn't identify as a caregiver at that time. I just called myself a supervisor on my dad. So I took initiative and started researching what to do. Somewhere along the lines, my dad's primary care physician retired, and we were given a new doctor. And I ended up sending a message, building a rapport with him, and asking him for referral. At that time, the appointment was anywhere from 6 to 8 months out, and it was going to take some time. In the meantime, what was we supposed to do? I didn't know about the Alzheimer's Association. I didn't know about all the other resources that are available at that time. But I started looking, started figuring out what to do. Once we got into a appointment with a neuro department, we ended up finding out that my dad was assessed with Alzheimer's dementia. And after that appointment, we were given a folder with community-based resources and said, here, call these people. And that was kind of it. There was no clear pathway to understand what's next, how to support a loved one that's going through these challenges. It's hard to convey the impacts that we as a family were going through. We were faced with, trying to preserve my dad's dignity and his independence with himself, all the while he's forgetting how to do certain tasks. It was a challenge for me because of the conflicts that we were having. I was trying to respect my elder, the parent that raised me, taught me everything I knew. But I had this illusion of what I thought was best for my dad. There's no manual, there's no clear guidelines how to care for your loved one. And I think what this topic that we're trying to express is, how do we get the information to family caregivers early on and support them through this journey? How do we take the steps to ensure success in defining dementia care? How do we normalize it? How do we rethink and reimagine dementia care, incorporating a family-centric approach to caring for not just the person, but the family? I think it's open for discussion to see how we can support family caregivers through this journey. It's a complex issue, but I think being a part of this committee, we can start taking steps to educate, spread awareness that family caregivers are a part of Alzheimer's and related dementias. So we need to support, we need to build networks and grow this community. We are all part of the care partners, and we need to kind of embrace that tribe community together and take light in it, embrace it. So thank you very much for listening, and I hope we can make change and support caregivers in California and across the nation and globe.
Thank you so much, Carlos, for sharing your story. This is just one story. I hear this every day. And I wish that we can do more and more. And I'm glad that we have this committee that's advocating to really support our caregivers. I think we'll move on and we'll pause for questions later on. So we'll have Mark. Go ahead and take it away, Mark.
Okay. And Kelly's just getting me set up right now.
But we were unpinned, so I can't change the name.
It's okay. Yeah, I can just speak. Great. Well, thank you and good morning, everyone. Great to see you again. I was at the last committee meeting talking on this very same topic, the no wrong door system. We have my slides.
Yeah, Rosie, well, is she not? Yes.
Okay. Okay, great. So some of this you would have heard from last presentation. This presentation is a slightly updated version of what I presented last time. It has more, I'd say, information and support for developing no wrong door system. And then I'll also provide some updates in terms of where we are in developing our system. Briefly, I'll be talking about 3 topics: navigating the LTSS services and support system, no wrong door, and how we think that the no wrong door system will help everyone, you know, speaking to Carlos's story, really become aware of different services and supports and what different entities have to offer. And then what are the key elements of a no wrong door system? Next slide. Great. So as Anna had said, you know, we always want to start from the person-centered view. It's one thing to talk about the theories and concepts and frameworks of what a no wrong door system is, what it's intended to do. But I think we have to really start with what problem are we trying to solve. And so we created these human-centered profiles, starting with an individual with a disability. We named him Ben. And, you know, again, a lot of these stories, all of you have already heard, but, you know, you could have somebody who, you know, uses a wheelchair and they might need assistance in their home with personal care assistance, modifications, equipment, peer support. And I think the question that we commonly hear is, where do I go? Where do I find these services? Next slide. The second profile is an older adult who needs assistance. And in this case, we named her Maria. And this is someone who had lost her husband and is now living alone and is struggling with some cognitive issues. So the kind of services and supports she may be looking for is basic HCBS services. It could be home delivered meals. It could be transportation, fall prevention services, memory support, as well as social engagement. Next slide. The third profile is caregivers, as we just heard from Carlos. So, you know, again, a lot of struggles and stresses, caring for somebody who may have dementia, as well as caring for like other people in your lives you may also have responsibility for. It could be children, it could be other relatives. Respite care, always a key issue. Caregiver support, adult day services, and then just planning services. Next slide. And then the last category is really professional. So this could be clinicians, this could be direct care workers, people who really work with the populations that we serve. And so having a no wrong door system can help them understand what resources they could offer to their clients. Right now, it could be a mystery, and a lot of information gets spread by word of mouth, either knowing somebody or being aware of a community organization, but it's really hit and miss. So how can we actually get information and access to information for people about all the services that we have to offer? Next slide. Okay, so this speaks to what Anna started with. All of these issues that these different, populations encounter are really as a result of our fractured system of services and supports in California. If you want a service or support, you may wind up contacting 5 different organizations. If you need help with transportation, you could be contacting a local transportation agency. If you need housing support, it could be a state agency, it could be a local agency. If you need meal support, again, a variety of different meal programs, could be congregate, it could be home delivered, could be food banks. But there's really no central place where all these populations can go to really see what the universe of supports are and have assistance navigating those supports. And that's what really the No Wrong Door system is intended to help with. Next slide. So again, defining the problem. Again, to all of us in this room and on screen, I don't think any of this is news. This is a survey that we did called the Community Assessment Survey for Older Adults in 2023. It was a statewide survey of older adults throughout California, and we measured them on a variety of different challenges that they have. And this really rose as one of the top concerns that they have, really not having enough information about services and supports in California. So only 30% of these populations think that in California, you get good to excellent support in navigating LTSS services. But that means 2 out of 3 older adults in California feel like they either don't have access or very limited information about access to services. Next slide. And similarly, ARP does a long-term services and supports scorecard. So they look at the quality of navigation systems by state. In California, ranks in the weak category, which given our size and demographics, population is just hugely concerning, right? Although we have an aging and disability resource connection system in place, this is a collaboration between local area agencies on aging and independent living services to act as kind of like local no wrong door service hubs. It's not statewide, and I can tell you every ADRC does their business a little bit differently. And we don't have a no wrong door system in place. So it makes sense why we'd fall in the weak category. Next slide. Okay, so what our vision is really to produce a single accessible system to all of our populations that also allow people assistance with navigating different resources. So really structuring that service model. Next slide. These are the, oh, sorry, one before. So these are all the different elements. I won't get into each one of these elements. That'll take a long time, but I will highlight just a few of the key elements that we're looking at for the No Wrong Door system. Next slide. So really where we start is having a governance structure in place. And we were very fortunate 2 years ago to receive a grant from the Administration for Community Living to help build out what's called the No Wrong Door System State Leadership Council. So we currently have 5 departments participating in that council. CDA and Department of Rehabilitation are the leads on the council. And then we've got Department of Developmental Services, Social Services, and Healthcare Services as additional partners on the council. In terms of who would actually help and assist with these services at the local level, we're really identifying our local area agencies on aging and independent living centers. They tend to be the go-to organizations to help older adults and persons with disabilities at the local level. So we think it makes sense for them to act as these resource navigators. And then, of course, to actually, assist people, you have to have providers in place. And we are very fortunate in California. We have a very robust system of providers. We talk about Alzheimer's organizations and caregiving resource centers, housing departments, transportation departments, IHSS, meal providers. We always say, our AAAs, our ILCs, and our providers are the best kept secret in California because most people don't know that these services actually exist or that these providers exist. Next slide. So this is the structure of what a no wrong door system would look like. At the very top of the structure, it would be our state partners. So I talked about our state leadership council. And as we expand our no wrong door system to really encompass additional services such as housing or transportation, that state leadership council would expand over time. We would look to establish what's called a provider directory. So this is really a single central website that people would use to see what service offerings that we have. It would have a description of the different services, as well as a searchable directory. You could do it by zip code, county, and then service type to really drill down to see what services are available in your area. And for those of you who've seen maybe 2-on-1 websites, you kind of get the idea of what the provider directory might look like. Next level down, as I mentioned previously, you'd have your local area agencies on aging and independent living centers. That would be those local hubs to help people navigate services in their area. And then there's the variety of different providers that they would work with that I mentioned. Next slide. So in terms of a service model, and this really speaks to the navigators, if somebody goes to, say, the Central No Wrong Door website and they're exploring different options, they might have questions. I don't know this provider. I need more information. Would they serve my needs? They would then be directed to a local area agency on aging or independent living center. The current model, and it really varies among AAAs and ILCs currently, you could ask for your local congregate nutrition site. They'd give you the name and phone number of that site, maybe website, and then that would be the end of the call. What we hope to do through a No Wrong Door system is really enhance that through what we call enhanced INA. So that would really be options, counseling, and referrals. If somebody calls to ask about a congregate nutrition site, you could say, do you have transportation to that site? And then you might invite them to engage in a conversation about, do you have legal assistance needs, or do you need chore help at your house? So it would really be opening up the universe of other services they could receive. And then finally, the third tier would be like crisis management, crisis counseling. If somebody's being evicted from their house, if they're being discharged from a hospital and they're going back to their home and they need really a package of case services, that's where you can have a case manager at a AAA or ILC really help put together that package. Next slide. And this would be the basic operating model, a little bit of a messy structure, but if you look at the left-hand side, you have the system users, which were all the profiles that I mentioned at the beginning of the presentation. Their initial entry point likely would be the No Wrong Door website, and then they would navigate that website, find the services. Some could self-help. If they find providers that work for them, they could. A lot of these websites have descriptions of the providers, addresses, phone numbers. They could just contact them directly for services. But if they need additional help, they could go to your local navigators. And then those navigators not only would provide them information about the services, but they'd also provide warm referrals. So getting the provider on the line, transferring the call, really helping them in that respect. And then, of course, they'd be receiving the services directly. Next slide. So just an update, and I know a lot of this I covered in our prior presentation. Last year, our communications department put out just this brilliant aging resource guide, a hard copy guide. We also have it in an online format that describes all of the key services and supports that help older adults, not only programs that are offered by CDA, but also other departments such as social services, so that they really, at least in that way, can navigate services. The next iteration, as I mentioned, is this central directory, or what we call the resource hub. We did meet with a variety of vendors in the fall to talk about their service directory portals, and we were very impressed. There's a lot of providers that are willing to work with us to provide this via contract. So that gives us a lot of hope that we would be able to launch this system. And then the contact solution. So again, this is our local navigators. Before it launches a system like this, we'd really want to work collaboratively with the AAAs and ILCs to make sure that they have the resources to provide this enhanced level of assistance. And also that they'd be prepared for the additional calls that they may receive once we have a No Wrong Door website up and running. All right, next slide. And then marketing, branding, and outreach. Again, you can build a great system, but if nobody knows the system exists, then what's the point? So we're spending a lot of time right now working on some branding around the system. The first question is, what do you call it, right? Because, in government, we love acronyms. I throw around terms like AAAs and ILCs. If I mention those to my friends, they have no idea what I'm talking about. So it's like, what's a really simple, easy to understand name? It could be, like even the term No Wrong Door isn't going to make a lot of sense to most people. It would probably be like Aging and Disability Resource Center or Resource Hub, something that's really descriptive and plain language that people can really relate to. So right now, that's kind of the first thing, is giving it a name, and then probably some sort of logo, tagline. And then once we get to that point, it's really going to be about marketing. How do you put materials together that will be attractive to people, that will get them interested? And then outreach. So we would probably do a lot of information through social media, maybe through online, radio spots, ads, maybe TV ads, get some word of mouth going, but also working closely with providers and other professionals. Right now, we hear a lot of people hear about, AAAs and ILC services through like professionals, like clinicians and places like that. So, who are those local providers that can really get the word around? But yeah, what we've heard in other states doing our research is that's really how a No Wrong Door system is best publicized. It's mainly through word of mouth, really just getting the word out there. So yeah, next slide. Yeah, and that's basically it. Just want to provide you a brief update on where we are with the No Wrong Door system. Right now, a lot of work just being done on what an enhanced information assistance service model looks like, doing some work on branding. And then, like I said, we did some research on what a website would be and who could provide that website. In terms of implementation, a little uncertain right now. We still have a lot more research to do. And of course, launching a system like this would require money. So, we'd also have to look to secure funding for this. But yeah, just wanted to provide an update on our No Wrong Door work, and happy to take any questions at the end.
Thank you so much, Mark. For the interest of time, we're going to move forward to Brian to share Health Connect update.
Good morning. Can you hear me okay?
You sound great, Brian.
Excellent. Thank you, Carol. I just want to say thank you so much for this opportunity to share an overview of CDA's CALS Connect program. My name is Brian Carter. I'm a manager here with CDA's Division of Policy Research and Equity. Before I get started, I would like to acknowledge that today, May 1st, marks the beginning of Older Americans Month and Mental Health Awareness Month. So today's robust discussion about Alzheimer's disease and related conditions seems quite fitting. All right. So the source of CALS Connect funding stems from an Administration for Community Living Cooperative Agreement, Alzheimer's Disease Program Initiative grant for state entities. The objectives of the CALS Connect program, one of the objectives is to create and sustain a dementia-capable home and community-based services system for people living with Alzheimer's disease and related conditions and their caregivers, using, as Mark pointed out, a no wrong door approach. We also have an objective to ensure access to comprehensive, sustainable set of quality services that are dementia capable and that provide innovative services to people living with dementia and their caregivers. Next slide, please. Now, in developing the proposal, the CDA team looked at evidence-based models and ultimately selected the Care Ecosystem Program. which was developed by the University of California, San Francisco. Some of the reasons the care ecosystem model was chosen is because, one, the support is provided by telephone, making it more accessible in rural and remote areas, and helps reduce barriers to access for marginalized groups. Barriers such as transportation, language access, or even a lack of internet connectivity. It's also a comparatively low-cost intervention since it uses allied health professionals as opposed to licensed personnel. And as we look at projected demand and the growing population of people living with Alzheimer's and dementia in California, its practical application makes it more scalable and replicable across the state. Now, in addition to care ecosystem, we've also incorporated home meds, which is an evidence-based tool for identifying potential patient medication-related hazards. A plan to safely manage prescription and over-the-counter medications is critical to avoid medication-related problems. The home meds involves a pharmacist consultation and recommendations where the system flags potential issues. Home meds is being offered to both persons with dementia and their caregivers because caregivers often have medication issues of their own. And home meds is also important for CDA since our program is not based in a healthcare system. All right, next slide. So I'd like to now tell you about the multidisciplinary team that is involved in the CALS Connect program, because the program design incorporates the core components of the care ecosystem evidence-based protocols to support a person living with dementia and the needs of the caregiver. The protocols address safety, behaviors, caregiver support, and advanced planning. And the care ecosystem model is both person-centered and customized. CALS Connect involves a multidisciplinary team, which includes the dyad, which means the person living with dementia and a caregiver. The caregiver can be a family member, a friend, or paid staff who supports the person living with dementia and is willing to participate in the program. It also involves a community health worker or incorporates a care team navigator who builds rapport with the dyad, learns more about their situation, including their stories, their values, their preferences, resources, and their living situation. The care team navigator helps them personalize their care to actively support the dyad and empowers the caregiver to be an advocate for the person living with dementia. They provide support, linkages to community-based resources, resources on advanced care planning, and care coordination. The CALS Connect program utilizes community health workers to fill the role of care team navigator. Then there's the clinical team, which the program also incorporates the support of a clinical team who are individuals with Alzheimer's and dementia expertise. The CALS Connect multidisciplinary team includes a Master's of Social Work from Alzheimer's Los Angeles and a registered nurse consultant from the Partners in Care Foundation. The multidisciplinary team meets frequently with the community health workers to offer guidance and discuss cases, and they are also available for consultation when needed. Please advance. Now I'd like to talk about the project partners who are involved in our project and administering the program at the local level in their respective communities. We have 2 area agencies on aging located in Imperial and Ventura, and the Marin Center for Independent Living. Now, each of these agencies serves older adults and people with disabilities through a designated or developing Aging and Disability Resource Connection program. Again, referring back to Mark's presentation. We're also in the process of onboarding a fourth community health worker at Alzheimer's Los Angeles. Now, CDA selected these sites for the strength of their existing programs and for their geographic diversity, representing Northern, Central Coast, and Southern California. Now, in choosing these partners, we looked at factors such as size and diversity of the older adult population, the prevalence of Alzheimer's, and the percentage of older adults who were Medi-Cal eligible. And just to provide an example, Imperial County has the 9th highest Alzheimer's prevalence of any county in the nation, according to a 2023 article published in the Alzheimer's and Dementia Journal. Now, by utilizing the Aging and Disability Resource Connection programs, this approach will provide streamlined access to dementia care information and supports within a community hub that offers resource navigation, assistance, and care planning. We also have an MSW, or Masters of Social Work, Doctor of Education from the GIGAS Group, acting as a third-party evaluator for the program. Next slide, please. So what are the outcomes? Well, the summative evaluation data collected to date, specifically related to caregiver burden and quality of life scores, has been promising. The data has revealed that caregiver burden scores were trending in the right direction. Evaluation of the pre and post scores showed that the sense of burden decreased as participants exited the program compared to when they started. Additionally, quality of life scores were also trending in the right direction. Caregivers were reporting that the quality of life of the persons with dementia had increased from when they started the program to when they completed the program. Now, these scores confirm that support being provided by the care community health workers is helping to reduce caregiver burden and stress and increase the quality of life for the persons living with Alzheimer's and/or dementia. And we are also confident in the development of dementia capacity, not only in California's project sites, but eventually throughout California's No Wrong Door network. And with that, I'll turn it back over.
Thank you so much, Brian, for giving that quick update. I know a lot of my patients and their family members have been benefiting in Marin County from this program, so I can share that it's been positive. Our next presenter is Allison from Bridging Aging and Disability Networks. Thank you so much.
Hi, thank you. Wait for my slide. Good morning, everyone. Thank you for having me here today. I am Allison Giannini. I am with the Department of Developmental Services, which I'll also refer to as DDS. I am very excited to discuss the Bridging Aging and Disabilities Network grant, which is being co-led by DDS and the California Department of Aging, or CDA. Next slide, please. A little bit about the Bridging Aging and Disability Network grant. You may hear it referred to as BADN or BADN. The Administration for Community Living, or ACL, awarded this grant to the National Association of Councils on Developmental Disabilities, or NACDD, to build a community of practice with the objective to better connect programs and services for individuals with intellectual and developmental disabilities, or IDD, and aging programs at the state level. The NACDD was tasked to build a national community of practice of 15 states, and they made it to 17 states. The work group for each state, which forms that local community of practice, is referred to as our State Alliance team. CDS and CDA co-leading this grant together. It is a 5-year grant. We entered in the 2nd year of the grant. Each participating state or territory is working to improve support for individuals with intellectual and/or developmental disabilities and their families as they plan for the future across the lifespan. The State Alliance team is made up of representatives from state departments, agencies, and community-based organizations. Each local community of practice was responsible for creating a work plan responsive to the grant's objective. Next slide, please. Oops. I think we need to go back one. There. Yep, that's perfect. Thank you. Therefore, the California State Alliance team, which is our local community of practice, created a robust work plan responsive to the grant's objective, which is improving aging services for individuals with IDD as well as their aging families. Overall, the State Alliance team, through the work plan, is set to accomplish the following. Establish a statewide community of practice, which we've done, with the mission to bridge IDD and aging networks to support aging individuals with IDD and their caregivers. All of our goals are aimed at not only people with IDD who may be aging, but also their caregivers. As I stated, may be aging because we also want to emphasize the needs for supports and services for the caregivers who may be aging. The individual accessing our system may not be encountering age-related experiences, but perhaps their caregiver is. So how can we leverage these resources to be responsive to the needs of the caregiver as well? We are also working to increase the accessibility of culturally and linguistically responsive age-related services, resources, and supports for aging individuals with IDD and their caregivers. So in other words, identifying the existing resources and supports, identifying gaps, and supporting with the navigation to services. A component built in throughout our work plan is the concept of leveraging existing resources. Therefore, what are the resources that are out there? How can we increase ease of navigation to them? Increasing navigation by culturally and linguistically responsive information sharing for families and entities that serve them. Creating informational materials that are categorized, organized geographically, and presented in a variety of languages and formats. Additionally, we are working to increase availability of culturally and linguistically responsive future planning services and supports for aging individuals with IDD and their caregivers. This also ties in to the navigation of resources through creating an inventory of culturally and linguistically responsive tools, best practices, and resources for that future planning. Next slide, please. So a little bit why this partnership and this grant are so important. As we know, as our life expectancy increases, our support needs may change. There are currently more than 450,000 Californians with IDD served by our regional center system. In the category of individuals aged 40 to 59, there's currently a little over 43,000, and individuals 60 years and older, there's a little over 20,000. Of that 60 years and older bracket, a little over 2,500 of those individuals also have a diagnosis of Down syndrome. Per the fact sheet provided by the National Task Group on Intellectual Disabilities and Dementia Practice, adults with IDD can develop dementia as they get older. The types of dementia that affect people with IDD are similar to those that affect people without such disability. And studies in the United States have found that the prevalence of dementia in persons with IDD to be about the same as in the general population. However, Alzheimer's dementia is the most prominent type of dementia among adults with Down syndrome. There's also a higher rate among younger adults with Down syndrome. So about 20% of adults with Down syndrome, age 40 years and older, have Alzheimer's. Onset of Alzheimer's disease generally occurs in adults with IDD in their late 60s. However, for adults with Down syndrome, as I was discussing, onset can be much earlier, generally in their early 50s. And most studies show that the average age of onset is around 52. For the other types of dementia, there's more variable ages of onset. And the National Down Syndrome Society recognizes the study by Fortea et al. 2021 and has stated the risk of developing Alzheimer's disease increases with each decade of life after the age of 40. And the overall lifetime risk of developing Alzheimer's disease for an individual with Down syndrome is more than 90%. Next slide, please. And so on this side, shifting gears a little bit, we're looking at the population 40 years and older by living arrangement. I included data for people with IDD as young as 40, and I did so because even though someone in their 40s may not be navigating age-related experiences, they quite possibly have a caregiver who is. And looking at this data, we see the largest number of folks are living at home with a parent, family, or guardian. So again, really focusing on not just the individual with IDD who is aging, but also their caregiver. Next slide, please. And then on the flip side of that, when we, sorry, I just got a weird notification. I don't know if anyone saw that. Okay. On the flip side of that, when we graph the data looking at individuals 60 years and older, the percentage of individuals living in the home of a parent, family, or guardian drops to 20%. And the percentage of individuals in a community care facility increases to 33%. So they flip. So we see that in that age range, right, when we transition as we get older, our living arrangement changes, and there is a whole host of new services and needs that may be necessary. Next slide, please. And lastly, as part of our State Alliance team, we have added an Aging Inclusion Resources webpage on the DDS website. This went live in November of 2024. We created this webpage to establish a presence and representation of aging inclusion in the DDS website, as well as to be a repository for the work being done by the State Alliance team on the Bridging Aging and Disability Grant. And thank you, Ranjana, for popping that in the chat. And next slide, please. Thank you so much. My email address is here, and I'm happy to connect further.
Thank you so much, everyone, for the excellent presentations. Now it's our committee's time to have questions and discussion about these important topics that we just shared. I know, Barbara, you raised your hand earlier. Do you want to go first?
Yeah, sure. So I'll start with the first question that occurred to me, Carlos, during your presentation, which I so appreciated. It's just a curiosity question. As a caregiver, did anyone along the way ever ask you what your needs were? What you needed to be supported in doing the caregiving?
No one asked me what my needs were until I called the Alzheimer's Association's 1-800 number, and they asked me how I'm doing. But that was years into my journey.
Yeah, I'm sadly not surprised by that at all. I hope that we are building systems at this point that are going to do a better job of that. So I know that people who are served through the state Medicaid, Medi-Cal program, CalAIM, that through a lot of advocacy, we built in their requirements for caregivers' needs to be assessed as well as the needs of the person who is living with the dementia. So I just thank you for sharing your experience and just highlighting that there's just more work that needs to be done there so that this becomes second nature to everyone across our healthcare delivery system, as well as the social support service network that families need to access in order to really address that full range of needs. And again, because our disease is one that changes all the time and those needs then evolve as well. So if we're going to help our caregivers navigate that, we just pay attention to them too. And I know everybody on this committee and in this room really knows that so well, but I just felt like we need to underscore that. My next question is to Mark. One is, so the hub that's being built, how is all that information, what's the plan for maintaining it? Because I just know that it's, when we do our own resource guide for Alzheimer's Los Angeles, it's challenging to make sure that we are presenting just the most updated information. There's a piece of legislation in this session trying to get healthcare providers to have updated provider directories. They don't do a great job of that either. So that's just whenever you're building any sort of resource guide, I think ensuring that it's the right information, updated information, so people feel confident and like it's worth their time to look at it and use it. And it's just such a challenge.
Yeah, and again, we'd be contracting out for this with a provider. A lot of the providers that we spoke with, they do quarterly audits. We would have to learn more about what form those audits take. I know a lot of them are starting to try to use AI to pull updated information off the web to automatically update records. I'm sure they'd have to go in and just validate that information. They also provide the ability for customers to send them queries saying, this address no longer exists, this phone number nobody picked up. And then they would contact the provider and try to update the listing. But yeah, from what we heard, this is a challenge for a lot of providers.
Yeah. And I just have one more comment related to that. I'm hoping as you're building out this hub and this resource that you are thinking about just, again, how are people going to learn that this exists and access it, that you're seamless with 211 and 988.
Yes, absolutely.
Thank you.
Great. Thank you, Barbara. Dr. Kazi?
Yeah, thank you. I just want to echo Barbara's point here. I just saw a patient yesterday who cares for her 90-year-old mom with Alzheimer's, severe dementia, and she cried saying that, she hadn't dated in decades, and now she has to take her mom to all the parties and to her date, which I told her, this might be a really good test run, this way. So, but the amount of burden she had is clear. And one of the concerns I have, I also, we have similar discussions at the Commission on Aging. And to Mark's point, when we create this network, there is a concern about the ability for the end agencies, the agencies at the end, service providers to be able to handle the burden. And at the CRC level in San Bernardino, for example, in Inland Empire, they have a waiting list. They just do not have the capacity to handle and support the patient that I saw yesterday, for example. And I think there has to be some thought given to a parallel program to enhancing their capacity to be able to handle. I mean, I remember when the healthcare network was reorganized over the last decade or so here, the system overall, became overwhelmed with the amount of demand that came with that, and it's still dealing with the effects of that. So I can see something similar happening to service providers at the end. So just for perhaps future discussion, or as you talk to AAAs or ILCs, I see what we can do to help with that.
Dr. Claire, you had a question or comment?
Yeah, thank you. It was just sort of to add on to what Barbara was talking about and something that I know you're aware of, but one of the issues that we've seen with similar resource databases is classifications of how California licenses buildings plays an impact on what gets pulled into some of those searches. And we've had some instances where inappropriate, like a sober living facility, for example, could be pulled into those searches. And it can be very frustrating for caregivers who are just trying to find the right level of care. So thinking of how California's licensure fits into that is a real key component for you to keep an eye on.
Yeah.
Yeah, I'm sure you're well aware, but
Yeah.
just an experience we had.
Yeah, we've encountered that same issue with other systems where somebody thinks that they're going to a certain type of facility,
Yeah.
but it's not licensed that way at all.
Yeah.
Thank
So
you, Claire.
Yeah. It's a big challenge.
All right. Anyone else with a question from our committee? I do have one thing for Mark too. But anyone else before I ask my question? All right. Well, thank you for sharing the structure on how the programs have been shared in local counties. I work in a health system. I'm just trying to see if there's opportunity to get the health system more actively involved with all of these progress, rather than waiting for AAA to, ask what's there. I think right now what I'm experiencing, it might be an individual basis. If a social worker happened to have new information from a AAA, then they may or may not share. But is there a I guess, a plan to make this more intentional so that the health plans or the health system will know all of this information? So even as a provider, as a clinician, not being a social worker, we'd still have some information that we can share with patient and or family members, as it does carry a lot of weight when we know that kind of information firsthand.
Yeah, absolutely. Yeah, as we build out the system, we would continue to do these types of presentations to a variety of different provider forums to make sure that people understand that one, the system exists, how to operate and use the system, what's in there and what's not in there. And we've had some really good conversations with DHCS just around how to get information out to like medical providers and how to, share information about like Medi-Cal and what's offered through Medi-Cal without going too far in that direction. I think that's one thing that we're really cognizant of is building enough boundaries around in terms of what we would include as a listing in a provider directory, services that most people would have access to and be eligible for versus, services that may require some sort of eligibility review prior to receiving. So yeah, absolutely trying to put those parameters in place. And I really appreciate the comment about local provider capacity. I think that is something we've been hearing from our AAAs and ILCs as well. Yes, this is great. It would be great to have a central system. However, if they're flooded with phone calls, do they have the capacity to take those calls? And if we get higher demands for local services, do our local providers have the capacity for those services? So what we might consider doing is actually piloting these out in select counties first, just to see, ones that have maybe more robust structures and systems in place to make sure that we understand what the uptick in demand would be once we launch outreach and marketing for these services.
Okay. I think we're right on time. Carol?
Barbara had her hand up.
Oh, I didn't see that.
Sorry,
Go ahead, Barbara.
Just one more thought. I just wanted to highlight something else from Carlos's story that he shared, and that was that experience of getting a diagnosis and then nothing else, just walking out of that doctor's office, having your world rocked and not knowing what your next step should be. I think it highlights that, and I do hope that that experience is less frequent now than it was perhaps back in, I think you said, Carlos, 2015. But it just highlights that it is still and forever, I think, going to be that doctor's office where everybody is at some point on this journey and where that information about the no wrong door system and the hubs and all these things get created, that information needs to be given to these families, whether it's a case manager that's in that doctor's office, however that's structured. That is such a key place. And I know doctors are so pressed for time, it's hard. But that's such a key touch point for sharing information and empowering individuals living with dementia and their caregivers to walk out of that office actually knowing maybe not what the next 10 steps are, but at least what one step is, walking out with something other than nothing.
Sure. Thank you. I think I saw Jason first and then Sally.
I just wanted,
to Barbara's point, in one of the earlier presentations, I was just quickly looking at some of the resources that were shared. Those are phenomenal. If there were just a simple flyer, a little card that could be distributed to physicians who service older adults, that they could just pick up, it's a wonderful starting place for them.
Thank you. That definitely will be helpful for us. And I think the request is also to make sure they're updated. That's one issue that I could see from that, but that would definitely be helpful. And no, I know sometimes folks are saying the physicians have a lot of things going on already, but we work as a group. We could find ways to make it work. We could have our medical assistant maybe share some information, just create some processes so that people actually, the caregiver is part of the care team, right? We need to be able to provide them resources to be able to then help the patient per se. Jason, I know you have You raise your
Sure.
hand.
I may be getting some of the details wrong, but a couple of years ago, CMS introduced a code for cognitive care planning with the intention of making this process kind of a billable thing to encourage providers to do some of this work. I do think that it'd be really interesting to talk and review how that interfaces with the kind of the caregiving supports, because right now it is care receiver focused, of course, but I think that's a really good opportunity, hopefully, to create a structural change to help offices do that kind of work and have a way of getting reimbursement for it and making sure it happens at that level as well. I don't know all the ins and outs of cognitive care planning. We usually let our PCPs bill that code instead of the specialty centers, but the point is to try and get some of these things all tethered together, the biopsychosocial aspects of care, including caregiving.
Great. Thank you, Jason. Anyone else? I think it's time for public comment, Carol.
Great.
All
Thank
good
you.
discussion.
Great. Thank you so much. Rosie, if you want to bring up the there we go. Good afternoon, everyone. This is the public comment period for our public attendees. Anybody's in the room and wishes to leave a comment, raise your hand and one of the staff will call on you. All our attendees online, please press your raised hand icon on your Zoom functions. Mine are down at the bottom. I don't know where yours are. And we will unmute your line. And if you're on the phone, *9, and that will indicate to us. And of course, at any time, if you wish to write your comment, I always like a minute to think. Feel free to email us at engage, ENGAGE, at aging.ca.gov. And that is monitored 5 days a week. We're happy to respond, send it on to our team members that may have a response, or send on to the committee in this instance. It has been a lively discussion today. We have learned quite a bit. We can give it just a little while longer. We will have another public comment period in the afternoon. It is slated for 1:15. And I do want to remind you, we do have the Q&A function live. So if you have a question that you would want to put in the Q&A, feel free to do that at any time. And it will either be answered live, responded to in writing, or we will let you know that we'll get back to you. Dr. Canio, I am not seeing any hands, so I'm going to turn it back to you unless you would like it to go a bit longer.
Anyone else has any more feedback? I know, Barbara, I saw your comment earlier. Since we don't have a public comment, we do have a bit of more time to keep discussing anything else we'd like to discuss for this topic. So the guide model should also move this in the right direction. And I know Dr. Kazi also commented that he just signed up to utilize the guide program earlier this week, and it will be our first direct experience with it for a number of our patients. I agree. I think the guide model, I think, will help us out. I wish all health systems are able to leverage this, but I know it's a pilot. So hopefully we'll learn more from this pilot and see how it will be spread throughout.
Dr.
Oh,
Canio,
sorry,
there is a Q&A. Let me read it out loud for you. This is from Jessica Studarus, Studarus. I didn't hear any comments about the new dementia guide program available via Original Medicare. How are your plans dovetailing with this existing initiative?
You want to address that, Barbara?
So I'm not sure I understand. So if I get this wrong, because I'm misunderstanding the question, my apologies. If this is a reference to the guide model, then as Dr. Kazi said, it is you have to apply to be part of it. And it's an 8-year pilot project. So I think, the goal with any pilot project is that you learn a lot, and then if things are working, it gets expanded across a broader program like the Medicare program, or if you're a dually eligible, you're eligible for Medicare and Medicaid, that population as well. So again, if the question is related specifically to the guide model, which is pretty new, relatively speaking, I think again it is in its infancy, and so I think there's a lot depending on the choices that are made at the federal level, which I know we're going to talk about later in today's meeting, but hopefully that stays on track, and there's a lot that we're going to learn, and I think it's going to provide us with a lot of opportunities to strengthen our healthcare delivery system and what's available under the Medicare program to support people living with dementia and their caregivers.
I hope that answered your question, Jessica. I know it looked like Celine is also, her organization is participating in the guide model as well. So as you heard, there are a lot of different programs and services that are participating, and we're learning as we speak, and hopefully we'll learn more from them, and they'll share all of these learnings. Carlos, I know you're in the room. Anything I missed or anything you'd like to add from your folks there?
Yeah, thank you for including me on that one. I think it was a good discussion, how we're moving forward to support caregivers like myself. I am just one caregiver, but I know from being in support groups that there is a struggle and there's a need for support, and finding a resource to navigate through this is greatly needed. And we need support from not only our doctors and other professionals. Community-based resources is required to move forward, and give us some confidence.
Carlos, do you want to talk about how your peers come to you for, like, if they have questions and consult you on next steps and guidance?
Yeah, I think it's important that I've had some not family members, friends that have reached out to me because I'm out there on social media kind of explaining what things have worked for me and the knowledge base that I have acquired that provides them some guidance of how to take the next steps, what questions to ask a primary care physician to support their family member, or what community-based resources are out there that can provide them some insights to their journey. It's been helpful for me to give back because of all the information I've received from my research in seeking support from my journey. So it's empowering to give people some insight and shine light on the community that's out there that's not really open and into the mainstream. I think it's, I think we need more of that, and having the accessibility of it, to be, like Mark said, how are we going to market that? How are we going to have the outreach? I've learned a lot today so far, but how do we get that out there to someone that's just had their world rocked? How do we follow up and show them that there is some compassion and empathy, and give them a sense of a peace of mind, and encourage them to still have quality of life, and to reduce those burdens that caregivers do have. And it can add up fairly fast, and it could change in a moment. But if we structure it and give people some hope that they can find support, it's greatly needed.
Thank you, Carlos, for sharing that and being the voice of all of us here. I think all of us have some role as we learn new things in this forum. Whatever role we have on our daily lives, I think we can then also share. So I hope everyone that's listening would share what we've learned today. Barbara, I don't know if you always have something great to say. I don't know if you wanted to add anything else before we close this session.
I don't think so. I appreciate the discussion and the presentation. Very informative. Thank you.
All right. Well, perfect timing then, Carol.
Perfect. Thank you. I think we can bring up the break slide. Ranjana, if you can, is it a half an hour? It's a 30-minute break, and we are 15 minutes ahead of schedule. So we're back at 12 noon, right? Does that sound good, Dr. Canio?
I think so, as long as Susan will be back on time, or we can move things around too. I'll leave it up to our CDA folks.
I think we can go with noon unless other factors present themselves. How's that sound?
Sounds good.
All right. See you all at noontime. Thank you for your discussion and participation.
Thank you.
Okay, it is 12:01, and we'll be turning it over to Dr. Canio to take us forward.
Good afternoon, everyone. Let's go ahead and go to our next slide. We will have a committee update for this section. We have this slide up. So we've had some changes in our bylaws. And so during this segment, the committee will need to vote on approval of the bylaws with the recent addition. If we could have the slide, please. It talks about the membership composition, having a minimum of 17 members, maximum of 21 members. I'll kind of wait here. Yes, and then the policy planning and recommendations, there are some clarifications and updates to process. And so this is what we've had. Hopefully you've had a chance to read this bylaw updates from the email that was sent out. So just more information on what this requires broad stakeholder consultation, including individuals with lived experience, community-based and institutional providers, researchers, academics, and direct care workforce, advocates and relevant state agencies, and promoting cultural and linguistic consideration for diverse communities affected by Alzheimer's and related conditions. I think, Carlos, do you want to take it away?
Yeah, thank you. So you want to vote on the adoption of the bylaws, right? Or
Does the committee have what the committee members like to discuss or have any questions before we move forward to
Any questions or comments about the bylaws?
Seems very straightforward.
I don't see anyone. Okay. Yeah, I guess we can move forward to the voting. Go ahead, Carlos.
Okay, so I'd like to formally motion to approve the clarified roles and responsibilities within the updated bylaws as presented.
I move to approve.
Have a second. Have a second.
Sally and Claire.
The motion has been moved and seconded. At this time, I'll open the floor for any discussions or questions from members. I think we can proceed with the vote. I'll call on each member by name. Please respond with a A if you approve or nay if you disapprove. Dr. Neil.
Aye.
Carlos. Aye.
Yeah, Senator Eric Wynn doesn't vote.
Okay. Sally Bergman.
Aye.
Claire Day.
Aye.
Dr. Dolores Thompson.
She's not here
No,
today.
she's not here. Is Myra on?
Neither Myra nor Ken are.
Okay. We'll move on to Barbara.
Aye.
Dr. Mobley.
Dr. Mobley is not on the line.
Okay. Dr. Quasi.
Aye.
Celine.
Aye.
Julie. No.
Well, she's muted and her camera's off. So I don't know.
Okay. So we move on to, and is it Dr. Farias not here?
Correct.
So we move on. Right?
Did you have, so it has been The motion carries.
So the motion carries and our proposed bylaws are hereby adopted.
Great. Thank you so much, Carlos. Now we have our fearless leader, Susan Damaris, Director of CDA, to give us an update.
Hi, good afternoon, everyone. I don't know if fearless is the right word these days. There's a lot of fear swirling around in our network, but I'll take that. I'll take it.
And that's why you're a fearless leader.
It's good to see everybody. And great to be here with you this afternoon. I wanted to provide a few updates to everybody. I'm going to start with the positive, and there are positives. Today is the first day of Older Californians Month, and the department is leading a campaign. It's a continuation of our Start the Conversation campaign, where we make our aging resource guide available and encourage people to, we encourage younger people to talk with older people about what their needs and preferences are, and we encourage older people to talk with younger people and their peers about what matters most to them. So we'll be carrying that message throughout the month. The official theme for Older Americans Month is Flip the Script. We just had a really great session on rethinking aging. It's available. We recorded it, but it's about the messaging about how to speak about aging today. And that's the theme at the federal level is flip the script on aging and really think about how we talk and depict and portray there. Thank you, Ranjana. Thank you. It was a really good session. I encourage you in your free time to take a look at that. Other positives, our other fearless leader, Catherine Blakemore, was part of this effort, but the California Department of Developmental Services released a master plan for developmental services just about 2 weeks or so ago. I'm going to drop that link in there. I'm sorry I missed the morning session, but I think you'll find some really good information there. It was stakeholder-led, community-driven, and we're really excited to be working with the Department of Developmental Services on activation of their plan. And then I'll move to the federal level. All of you have various levels of understanding and information about what's going on at the federal level. And I've just returned this morning, in fact, from Austin, Texas, where I was at a meeting, a national meeting with Advancing States. That's a trade association of sorts of directors of state units on aging, Medicaid executives who work in the home and community-based services and long-term services and supports areas, and state departments of developmental disabilities. So we were honored to be joined by the current acting secretary and administrator for the Administration for Community Living, Mary Lazar, as well as many leaders from the Centers for Medicaid and Medicare and Medicaid Services, CMS. So I feel better informed than I did last week, having spoken and heard directly from leaders at the Administration for Community Living and CMS. So the things that we do know right now amidst all this uncertainty, we do know that area agencies on aging will be paid. They're under a continuing resolution right now through the end of September, the end of the federal fiscal year. I know some of you on this call are subcontractors and vendors with AAAs in our network, and there's been a lot of worry about payments, but we've been assured that those payments are forthcoming sometime by mid-May. So we heard that directly. We also know that the Older Americans Act. Do you hear my dog barking? Good. I do. The Older Americans Act final rule is proceeding, and it was acknowledged that it's an important direction for the Older Americans Act, and that will continue. There might be some adjustments and some tweaks to it. We expect probably in the area of diversity, equity, and inclusion that parts might be rescinded, but by and large, the policy direction of the OAA final rule will continue. We also know that grants, they're continuing to review grants. California just submitted for one around no wrong door and using community health workers, more actively using community health workers. We have no assurance that we will be selected, but we will be reviewed and considered along with others, and they expect those awards to be made in June. We also received a very small grant award from ACL to assist our LA County and LA City AAAs in their LA fire response, and that came to us in just the last couple of weeks. So activity is happening as ACL is being dismantled. First and foremost, their staff has been reduced in half. So they had just over 200 employees. They're down to about 100 now. They've eliminated all of their regional offices, including Faye Gordon, our regional administrator, who was outstanding. Those remaining 100 staff members will be divided among 3 federal agencies, and that will be occurring this spring and into the summer. So that's happening. The silver lining there is our aging and disability and family caregiving advocates have really banded together and have organized a number of letters and meetings with congressional offices. And I could not be more proud of our network for responding to these challenges. So we've got that. In terms of a triple threat, there's the federal, I call it governance, how things are organized and staffed. Secondarily, the second threat would be Congress has returned from their spring recess, and they're now marking up, they'll start marking up next week, the president's 2025-2026 budget. So we're watching that closely. That is where we anticipate Medicaid cuts or changes in Medicaid policy. And we're also watching very closely to see what happens with the Older Americans Act and at what level it will be funded. There have been some leaked documents that suggest that some of the OAA programs will be cut or slated for elimination. These are leaked documents. They're not final or official. So while they signal a direction, we don't know if any of that will stick at this point until we see what Congress, what the president and Congress put in print. And then the last piece is in about 2 weeks, we'll release the state's May budget revision. This is, for those who don't follow the budget closely, in early January, the governor always issues a proposed budget for the state fiscal year that begins July 1st. The legislature considers the proposal, makes their additions and deletions, and then in May, we true up the numbers when we see the state's fiscal situation, tax receipts, and caseloads. And we do know that tax receipts are down and caseload growth is up, and we have a lot of federal uncertainty. So we are expecting a pretty, probably not a business as usual May revise as we saw in January, and it is possible that we will see reductions in that mid-month. So we will share out with the network anything that we learn, and our Secretary Johnson of Health and Human Services Agency always convenes a stakeholder call the day that the May revise is issued, and all of you will be included in that to listen in if there are any changes that impact the issues we all care so much about. And with that, one other piece, in the midst of all of this, we are updating our state plan on aging. And we'll be releasing a draft document in June, and we will have a public hearing in Los Angeles and a virtual hearing for everyone statewide. So you'll see more about that. We do that every 4 years, and we'll be submitting that for approval in July of this year. So those were the points that I wanted to share from the Department of Aging, and I'm happy to take any questions or comments. I do just want to thank everybody. I know these have been some really, really challenging months, and it's hard individually, it's hard professionally, it's hard collectively, and we're working with a lot of uncertainty and ambiguity. While we know that the needs, as were articulated this morning with the No Wrong Door, as we saw from the Alzheimer's Association's Facts and Figures document released yesterday, we know that the needs for our population, older adults, people with disabilities, family caregivers, people living with Alzheimer's and dementia, are only increasing. So any questions? Comments for me?
What are the 3 departments where ACO is getting distributed to? Do you know that, Susan?
Hi, Celine, I do. So the programmatic work, most of the programmatic work is expected to go to CMS. The kind of the admin type work is expected to go to the Administration of Children and Families, ACF, and some of the work, I'm not sure which part, kind of the planning piece is slated to go to ASPE, the Administration for Strategic Planning and Evaluation. All 3 are under the HHS umbrella. So imagine just over 100 people divided among three federal agencies. It's not clear yet where the administrator would reside, where the leadership would sit. But I'll tell you that the acting secretary, Mary Lazar, said the mission and the work continues. She has a long history. She served previously with ACL. She's been in the aging field for over 30 years, and she did focus a lot on, sort of some of the themes that we're seeing around Make America Healthy Again and some of the feeding food programs, senior nutrition being a high priority. So she did speak to, some of the priorities for this administration. And we have an open door. So if you do have questions, not on the call, or you hear rumors and you want to chase them down, or something you think we need to know about, please pass it along. We're in it together.
Thank you, Susan.
Thank you.
We appreciate you.
I appreciate you.
We're gonna move on. We're gonna move on with Tina Fung, Alzheimer's disease section with the California Department of Public Health for some updates.
All right. Good afternoon, everyone. My name is Tina Fung. I'm the manager for the Alzheimer's disease program within the Chronic Disease Control Branch at the California Department of Public Health. I'll be providing some updates on our most recent work within the program. Next slide, please. So for our prevention pillar, we have the California Healthy Brain Initiative, which funds 13 local health jurisdictions to implement public health strategies that promote brain health. addresses dementia and support people living with dementia and their caregivers. And the initiative will sunset on June 30th, 2025. Right now, at our program level, we're in the midst of disseminating an evaluation report, highlighting the pilot cohort that worked on this initiative from 2020 to 2022. And that'll be posted on our CDPH webpage in the next couple of months. Next slide, please. In terms of the federal grants, for our CDC block grant, we are continuing to implement our community needs assessment for year one. The focus of this block grant is to establish relationships with tribal and rural communities and promote the Healthy Brain Initiative among these communities. For our BOLD grant, so BOLD stands for Building Our Largest Dementia Infrastructure. We are in the process of submitting our year 3 continuation plan to the CDC. And like Susan said, we've heard from the CDC there were some staffing changes, there were some reduction in staffing, but we are grateful to be able to continue with our continuation plan for this grant for the 25-26 federal fiscal year. Next slide, please. Okay, so for our clinical and caregiving pillar, ADP also funds 10 California Alzheimer's disease centers that provides dementia screening and diagnosis, as well as training for health professionals. And CADCs are currently working on revising their assessment of cognitive complaints toolkit for Alzheimer's disease. There's a link there, so if you have a chance, you can take a look at the toolkit. So that's their main priority for this year, and for this toolkit to be adopted and implemented at local clinics. Next slide, please. And again, ADP is partnering with 2 universities on development of caregiver trainings. The team at UCI, UC Irvine, is currently in production and beta testing their self-paced e-learning style modules. They're adapting their materials in Spanish and conducting online surveys for input. And at UCSF, they are finalizing their microlearning videos using live educational session recordings that highlight key dementia caregiver skills. They are also in the process of having regional senior community and cultural organizations review their caregiver training content. Next slide, please. And for research and evaluation, and at this time, our program continues to provide technical assistance to the 7 research grantees. They were awarded 2023. And they started their research in July 1st, 2024. Their research work continues until 2028. Okay, next slide. For the 25-26 state fiscal year, ADP intends to continue raising public awareness of brain health and dementia by promoting newly developed resources. We will also continue our partnerships with other CDPH programs that are related to aging and other state agencies such as CDA. And we hope to build new partnerships with tribal and rural communities through our work in the block grant. For funded partners, ADP will continue to provide technical assistance to our 10 CADCs, as well as our research grantees. And lastly, we will be beginning evaluation of the Healthy Brain Initiative within California for all 13 counties who were funded for this initiative. Next slide. And finally, the California Neurodegenerative Disease Registry from our sister branch, the Chronic Disease Surveillance and Research Branch, has announced the rollout of their Alzheimer's disease registry. The CNDR is California's statewide population-based neurodegenerative disease surveillance system within CDPH. In 2021, California enacted the Health and Safety Code, which requires CNDR to collect neurodegenerative disease information other than Parkinson's disease, which CDPH began collecting in 2018, excuse me. In 2023, CNDR started collecting data on multiple sclerosis. CDPH uses the data collected by CNDR to determine incidence and prevalence of these neurodegenerative diseases. Recently, healthcare providers are required to report Alzheimer's disease diagnoses to CNDR starting on July 1st of this year. So health professionals can find more information on CNDR's webpage, where a guide to reporting is available, and their contact information is there if anybody has questions about the requirements for reporting. Last slide. And if anyone has questions for our program, you can always email us at alzheimersd@cdph.ca.gov.
Thank you, Tina. Any questions or comments for Tina?
I've got one.
Is that Barbara?
Yeah, it's Barbara.
Okay.
So Tina, the CNDR, which I hear you saying that information gets used at least in part to determine prevalent traits. So my concern is that unlike the other diseases, or not to the degree, with the other diseases, Alzheimer's disease is underdiagnosed. So I'm really concerned that if you're pulling forward diagnosis information into it and using that as a basis for determining prevalence, that those numbers are not going to be accurate, like they might be for MS or the other neurodegenerative diseases that also report into this system. Can you just speak to that a bit?
I'm not familiar with CNDR. They are a program from our sister branch. But you do have a good point. And do you have any suggestions?
Yeah, it's a great. We actually didn't support this registry for Alzheimer's disease for this reason. But here we are, and it's being implemented. So I guess maybe that's a conversation about maybe, I don't know what that formula might look like for accounting for that underdiagnosis that we know exists. So the data will be interesting. It just won't be a complete picture. And again, in a way that's perhaps not the case with the other diseases. So I think I just wouldn't want to see numbers come out only based on the information out of that registry. So again, I don't know if that's an internal conversation between you and the partner agency, if there's, I mean, we'd be happy to be part of that conversation, but I hope somebody is thinking that through.
Do you mind elaborating on how the Alzheimer's registry is different from the other neurodegenerative?
In the sense of whether the other diseases go underdiagnosed to the degree that Alzheimer's disease does. I am not an expert on MS, for sure, or the other diseases, so perhaps this is an issue there as well. So perhaps there's already a way to account for that. Again, if this data is being used to set a baseline and determine prevalence rates. But that's what it comes down to. So if diagnoses of Alzheimer's disease are going to be reported in by doctors, that's not the problem. The problem is, all the dementia that goes undiagnosed that is therefore then not reported into the system. It's just not a complete picture when it comes to Alzheimer's disease and other forms of dementia. You just want to be careful how that data is used. Again, if you're putting out a prevalence rate based only on that, I'd be very concerned.
Yeah, Barbara, I'll just add to that. It's a few years old now, but I can certainly, Tina, provide you with the special report that the facts and figures had on diagnosis, but it's believed that about 50% of people living with Alzheimer's have never been formally diagnosed by their healthcare professional. So families just, they ignore the warning signs for all the reasons that we know about it. It's challenging to diagnose. It takes months and months and months. So it's just something for you to be really aware of when you see data coming out of it.
Okay, I appreciate your feedback. And we'll definitely bring this up with our sister branch and letting them know how they're analyzing the data should be considered carefully.
Thank you, Barbara, for asking that question. Anyone else with a question or comment? I don't see. Let me. Susan.
Yeah, I wanted to thank Tina, but also I'm going to share. I was, for those who are interested, Dr. Erica Pond's State of Public Health report and testimony to the legislature had some references to Alzheimer's and dementia. I'll share that link for anyone who wants to read up on that.
Thank you, Susan.
Thank you, Susan.
All right, anyone else? Thank you again, Tina, for always sharing great updates for us. I know there's some challenging times, but glad to hear that some of the programs are continuing, and hopefully we'll all have creative solutions to expand more things in this challenging time. So thank you. I think we're moving on to our legislative update. Barbara and Andrew. I don't know if Andrew's here, but I think Barbara will start.
I will start. I do think Andrew's here.
I'm here,
Yeah,
but
great.
happy to let Barbara go first.
So I'm actually going to start in a little bit of an unusual place. We can go to the next slide because I don't usually talk about federal activity. I just focus only on state legislative work. But here's the thing, whatever happens at the federal level flows in our direction. It impacts the state and the budget challenges we face. It impacts the healthcare system that our families access, and it impacts people living with Alzheimer's, dementia, and their caregivers directly. So it's hard to have a conversation about what's going on at the state level without acknowledging what's happening at the federal level. So I wanted to start by just, as you're watching the news and hearing about potential cuts here or there, and you may be wondering, does any of this directly impact this particular issue area? So I wanted to just give you a sense of, so you can be on the lookout for where some of the very direct Alzheimer's programs live within the federal government. And of course, there are other, we're touched by almost every aspect of the federal government, but here are some central issues. And Susan already spoke to the Administration on Community Living. And the first half of our meeting this morning, there were multiple examples of grants that came to the state to do important work that came from the Alzheimer's Disease Programs Initiative. They also house the National Alzheimer's and Dementia Resource Center and the National Call Center. The Food and Drug Administration is on here because anything that is coming out of the research world and moving out into being accessible by our healthcare professionals and our people living with the disease, it's got to be approved by the FDA first. That is a deliberative process by design. It is not speedy. So reductions there that could possibly slow down that process could then also result in advances in drugs and treatments not being available to people as quickly as they might otherwise be. So that's a concern that we're watching. Centers for Medicare and Medicaid Services, we've already talked about the guide model. We've talked a little bit about the state Medicaid waivers. We have a really big one here, the CalAIM program. So all of that runs through Medicare and Medicaid Services. They're the ones who are approving waiver programs and the rules around something like the guide program. So this is another agency that we want to be robustly staffed and funded. Center for Disease Control. It's so fantastic how the public health world has really embraced this issue of Alzheimer's and dementia and sees their place in addressing it. The BOLD initiative is a fantastic example of that. Important work is happening at the community level in my community in Los Angeles that's funded by the BOLD initiative, doing things like increasing early detection, which speaks directly to the issue that we were just talking about with the data. And then finally, what's probably very top of mind for all of us who are in this conversation today is National Institutes of Health, right? So this is funding all of that incredible research, and we don't want to see any of that slowed down. They're also operating the Alzheimer's.gov website. So again, if somebody's coming out of a doctor's office with a dementia, they're going to the computer and Googling things. This is a resource that we do still want to be available to individuals. So I'm going to talk a little bit, next slide, about what we are seeing proposed. So as Susan alluded to, the Administration on Community Living is currently being dismantled. These are the three directions, which Susan also talked to as well, which where programs are going. Next slide. Food and Drug Administration, you can see 3,500 positions cut. It's almost 20% of their workforce. So again, you know, all those folks there doing, you know, more with less. That's a concern that we will be watching. Next slide. Same over at National Institutes of Health and the CDC. So reductions at NIH of about 1,200, CDC staff reductions, which include, my understanding is, and I should caveat everything I'm saying, it's like an hour from now, something might come out that is a whole new announcement that completely changes half of what I've been talking about today. I mean, that's just, it's a really dynamic space right now. And so that's just something that we all need to keep in mind. But my understanding is that all of the BOLD staff at CDC have been placed on administrative leave. So what does that do to administering the grants that are in process right now? We don't really know. We're going to be watching to see what happens there. Next slide. Okay, so that's the administrative side of this. Now what's happening when it comes to the dollars? This is really a right now activity. So my understanding is, and Susan also alluded to the leaked document that had come out at least a few weeks ago. My understanding is that it could be today, it could be tomorrow, where there's actually an official release of, I guess they're calling it the skinny budget, which is sort of an overview of what the guidance is for the committees, the congressional committees, as they're determining where the real cuts. Like here's where the rubber's meeting the road. So the guidance given to, I'm just going to take, for example, the committee that oversees the Medicaid program, because there's been a lot of coverage of potential cuts to Medicaid. They would be devastating for the state of California and for our families if they actually play out this way. So they were given the guidance that they need to find $880 billion. That is over 10 years. And out of the nutrition program, $230 billion. Now what has to happen is the committee has to start meeting and actually lining that out. Exactly where is that money going to come from? How are they going to actually get to those numbers? So I want to just take a second to talk about what Medicaid looks like in the state of California. If we can go to the next slide. All right. So again, we call it Medi-Cal. And the Medi-Cal program is funded by the state and the federal government. So both are putting in funds that are providing healthcare coverage to 15 million Californians, birth to death. This is what provides access to skilled nursing facilities and the full range of healthcare. So those federal funds make up just over 60%. So any change in how the federal government funds the Medi-Cal program is going to be very difficult for the state to actually backfill. And there would be obviously ripple effects for all the other programs that we care about if that is indeed the situation that we find ourselves in. Again, we do not know at this point what this is going to look like. This is the next few weeks. I believe Congress is hoping before or around the Memorial Day weekend to actually have a budget bill that they would be voting on. That's very, very speedy, but perhaps it is indeed what will happen. So, be watching to see what comes out of these committee conversations. But there's another component of this that I think doesn't get as much coverage, but it's really, really important, and that's the next slide. If you're familiar with the Affordable Care Act, a lot of folks were able to get access to healthcare coverage through the Affordable Care Act and something called an exchange. Here in California, our healthcare exchange is called Covered California. And this is how about 1.8 million Californians get access to healthcare. And this is in part, at least, the group of people that we often talk about, like the missing middle, the overlooked middle. So these are people who make too much money to qualify for straight up Medicaid, Medi-Cal, and not enough money to really easily cover their health insurance costs and other healthcare expenses. So the coverage that they get through Covered California has been game changing for so many families, finally giving them solid access to healthcare. But a really important piece of how that happens is most of those individuals get some kind of subsidy to afford that healthcare coverage. That subsidy comes from the federal government. So if you hear cuts that are being proposed related to healthcare exchanges in the federal government, it's these 1.8 million Californians who might be at risk of no longer being able to afford to buy their healthcare coverage through the exchange. Next slide. I am not going to go into all of these, but these just again to put into your mind as you're watching news coverage, and then when these slides get sent out, I really encourage you to click on that link at the bottom, which is the Justice and Aging fact sheet. These are all the different ways that they might go about cutting Medicaid. And the one I want to focus on, and I'm actually going to drop something into the chat if I can talk and drop into the chat at the same time, is about the work requirements, because I do believe that that is going to be highly likely for work requirements to be put in place. And if anyone talks about work requirements as not being a cut to Medicaid, they are. And that is a really ugly looking link that I just put in there, but it's from the Commonwealth Fund and it just came out today. And it goes through the impact of work requirements. I think that's my last federal slide. We're going to slide over now to state legislators. And we can go next slide. Yeah, okay, great. Okay, on to happier topics. So I'm going to talk about a few pieces of legislation and a couple of budget asks, and then I'm going to hand it over to Andrew, and he's going to do a few more. So the first one is actually a piece of legislation.
We can throw in the other.
That Alzheimer's Los Angeles, Alzheimer's San Diego, and Alzheimer's Orange County are the sponsors of. And this one grew out of what we were hearing from some of our support group members who were saying that they were not able to stay with their loved one for the full length of their stay in the hospital beyond standard visiting hours, or they had issues where they as a family member just needed a break and they had a neighbor or a friend who could come and stay with the loved one, and because they weren't a family member, they were not allowed to stay beyond standard visiting hours. So the bill has been amended quite happily to actually expand the populations that would be covered beyond just people living with a cognitive impairment, to also include people with physical, intellectual, and or developmental disabilities, to just ensure that those family/friend caregivers are able to stay with these individuals while they're in the hospital and to really help facilitate their care, working with the healthcare staff to ensure that needs are effectively communicated and met. So this bill did pass out of the policy committee, and it's in Assembly Appropriations. We don't expect there to be cost to the state for its implementation, so we do hope that we will move out of that committee successfully and then pass off the Assembly floor when our turn comes. Next slide. Next two pieces of legislation, I think of real importance to caregivers. The first one, both of these actually were filed last session as well, and for different reasons were not successfully passed. So both of them are trying again. The first one is related to expanding the paid family leave program so that it would not just be limited to a certain set of familial relationships. What this also would do is line up California's paid family leave program with the federal job protections that already exist for family caregivers, which do include people like a designated person, a neighbor, a friend who's providing care. So I think this is one that really could again make it possible for our family caregivers to balance all of those competing demands and be able to stay home with their loved one for at least certain periods of time to provide care. This bill is moving, and so we are hopeful that this time it will make it across the finish line. The next bill isn't moving right now, and so I'm not sure about its possibility for passage this time. This is, so the Blue Envelope program already exists in some communities in California, in Riverside County and San Diego County in particular. And this would direct the Department of Motor Vehicles to make this program available to all of the counties in California. At its most basic level, you can do a lot more with the program than just this. It is a literal blue envelope that, for example, could be kept in the glove compartment of a car. If you, and let me just say, this is not just limited to people living with a dementia. This is also of great importance to people within the autism community. So if you were to have some kind of a law enforcement encounter, you could share the information in this blue envelope and help that law enforcement individual understand the dynamics of this conversation that they're having, and just ensure or try to ensure that it doesn't escalate in directions that are potentially dangerous or not productive. But again, this one isn't moving, so I don't know that we're going to see passage this session. Next. So a couple of bills, there are a lot of bills filed this session in response to the wildfire emergencies that we saw in January. We absolutely saw, as those disasters unfolded, that the needs of older adults were not effectively, quickly met in that chaos. And it is a chaotic situation. And so I'm happy to say both of these bills are moving. The first would relate to just ensuring that the area agencies on aging do have some kind of an emergency shelter pre-planned where older adults can go so that we can ensure that they continue to get the services they need. And then the second would be directing CalHHS to develop a work group to make recommendations about evacuation or sheltering needs for older adults and persons with disabilities in long-term care facilities. So again, both bills are moving. Hope to see their passage. Next. Okay. Back one. Neither of these bills are moving right now. But this issue of financial abuse is a really, really important one for the families that we serve. I believe, my understanding is with both of these pieces of legislation, there's going to be some conversation within the banking committee about how to kind of comprehensively address this issue. I do think both of these pieces of legislation would be incredibly helpful to our families. So I don't know if this is something we might consider in the committee's letter to the secretary, just to encourage the legislature and the committee these bills are going through to be able to move these issues forward and to be able to do something that would really help our families protect their loved ones from financial abuse. And then just two more budget items for me, and then I'll hand it over to Andrew so we can go to the next slide. And also to Susan's point that we are waiting for the governor's May revise, that we are all not expecting good news. So that is going to potentially complicate some of these budget asks. However, this particular one would be seeking funds from these two funds that I've noted here. So it's not general fund money. And so that does perhaps give this budget request a bit more of a chance to actually be enacted. Again, our families or our individuals living with a cognitive impairment or dementia do make up a very large percentage of people who are living in our skilled nursing facilities. They are obviously very vulnerable, and when they're in those facilities, and the Ombudsman program is absolutely essential to ensuring their safety. It is a phenomenal resource for our family caregivers. So I really, really think that this is a budget ask that, you know, we should absolutely do everything that we can to make sure that it is actually implemented. And then the last one, this also speaks to our conversation from earlier this morning, and these are the Aging and Disability Resource Connections program, the No Wrong Door. This would be one-time funding, and in a state as big as California, it absolutely needs more funding in order to move forward. What we know is just an absolutely critical component to ensuring that our families can actually find and access the services and supports that they need. And with that, I hand it to Andrew.
Thank you, Barbara. I'm Andrew Mendoza, the Director of State Affairs. It is nice to meet you all. I've been in this position since late February, so this is my first time being able to present in front of the advisory committee, and I really appreciate the invitation. If we could move to the next slide. So the Alzheimer's Association is sponsoring Senate Bill 412 by Senator Lamone, and this is creating a training requirement for affiliated home care aides on dementia-specific care. It adds in a provision to this effect within the existing requirement for home care organizations, 5-hour training block. We thought this was necessary to ensure a baseline level of training on Alzheimer's disease and dementia to ensure that home care aides are able to provide quality care to their clients that are living with dementia. And this will help prevent caregivers from experiencing fatigue by instilling trust that they can take a break for their own personal care and will not have to worry as much about a hired hand being ill-equipped to care for their loved one. If we can move to the next slide. So we're also sponsoring this budget request. Tina did mention the work that the California Alzheimer's Disease Centers, or CADCs, are doing, and they are in need of more funding. So these diagnostic hubs were founded in the 1980s to provide a geographically diverse set of centers focused on researching Alzheimer's disease, and they play a critical role developing a standard of care for treatment and conducting research on dementia. They have staffs comprised of neurologists, psychologists, clinical coordinators, and social workers. And to operate a center, they spend their allotment from the state and then find supplemental funding from elsewhere to finish paying off these salaries. So the center attached to USC that's servicing a portion of LA County, Rancho Los Amigos, is likely to close this fiscal year. And then another that's in Fresno may close the year after that. These closures would displace patients, increasing the distance and time associated with appointments to see these specialists. We would like for their budget to be augmented so that we can get closer to the actual operating cost, which is $500,000 annually. We currently spend 2.8 million on these centers. So we're asking for a 2.2 million budget augmentation, which would bring the state's annual investment to 5 million. If we can move to the next slide. And then, so these items that I will be talking about there hereafter are all the things that we're supporting but not sponsoring. So those first two were our main focuses. And then, so this is a budget request that is being championed by the California Association of Adult Day Services, and they're asking for a rate increase for community-based adult services. So CADS previously secured a rate increase, but they were not included in the provisions of Prop 35, so this progress was wiped away when that measure passed. And the association is trying to restore the increase that they previously received to keep these centers operating. They provide individuals with the opportunity to receive quality care in addition to respite for caregivers. A representative from CADS provided at a recent joint hearing of Assembly Budget Subcommittee number 1 and number 2 on Health and Human Services that centers have already begun to close and that more are on the brink of ceasing operations. There's additional pressure because managed care plans were provided with an inaccurate provider rate earlier this year. Now that the error has been detected, they're wanting to claw back that money from the centers, which could expedite even more closures. The current Medi-Cal rate for CBAS is $83.90 per participant per day, which is almost $50 below the estimated $131 per participant per day to operate a CVAS center. So this will help get them a bit closer to actual operation costs, but they have a series of plans to get them to full operational cost over many years. So this is one step in the process to get them closer to that goal. If we could go to the next slide. So this bill, oh, can we go back one? Thank you. So Senate Bill 470 by Senator Laird it was recently amended, and it now extends the January 1, 2026 sunset dates on provisions authorizing a state body to meet via teleconference. And it's going to now be moved to 2030. It also removes the requirement that any state body that is an advisory board, advisory commission, advisory committee, advisory subcommittee, or similar multi-member advisory body to meet via teleconferencing if a quorum of the members are physically present at the primary physical location for the meeting, and instead only requires that at least one staff member of the state body to be present. A piece of evidence that the sponsors have been using, which is the California Commission on Aging, is that the Little Hoover Commission conducted an analysis that provided the optionality for remote participation has cut costs from the state while increasing participation. And this bill provides equity and inclusion within a subset of the government by enabling caregivers and people with disabilities to serve on decision-making bodies that affect their lives. It made it through the Senate Governmental Organization Committee, and then the Senate Judiciary Committee, and the Senate Appropriations Committee. It's now on the third reading file of the Senate floor, and Rule 28.8 has been applied, so it will be moving to the Assembly shortly. If we can move to the next slide. Okay, so AB 508 by Assemblymember Aguiar Curry provides that a ratio of direct care staff to the patients that they are serving will be available to consumers at critical decision-making junctures, namely when a resident is admitted to a facility or whenever there's a rate increase, this figure will be provided to them so that they can make the best decisions for quality of care. The intent of this bill is to improve quality of care, which research has provided is closely linked to the availability of direct care staff. A resident's individual outcomes, including the presence of weight loss, bed sores, and general functional ability, are regularly linked to staffing. Additionally, there's a connection between higher turnover rates and lower quality of care. This bill is in the Assembly Appropriations Committee, and I believe it is awaiting a hearing. If we can move to the next slide. SB 530 by Senator Richardson concerning Medi-Cal time and distance standards. This bill builds off of AB 205 by Assemblymember Wood from 2017, which placed time and distance standards into the state statute after CMS promulgated these regulations in 2016, and AB 1642 by Assemblymember Wood from 2019, which required managed care plans to provide a set of information when requesting alternative access standards to provide transportation to enrollees required to travel far distances. Existing law includes neurologists in the list of specialists. In general, individuals can't wait an exceedingly long time for an appointment to see a neurologist upon referral, which is why we are supporting this measure. It has been placed on the suspense file in Senate Appropriations. We can move to the next slide. AB 315 by Assemblymember Bonta for Medi-Cal, home and community-based alternatives. So the HCBA waiver provides people with disabilities who qualify for an institutional level of care to instead receive these services in the community. Specifically, the HCBA waiver serves Medi-Cal members who, absent the waiver, would require care in an acute care hospital, a subacute facility, nursing facility, including skilled nursing facilities, or an intermediate care facility. As of December 2024, the HCBA waiver served about 9,300 people statewide, and over 5,100 people were on the waiting list. A February 2025 report commissioned by DHCS noted that there were gaps in access to the HCBA WAIT program because of the limited number of slots and long waiting times. This bill has been placed on the suspense file in Assembly Appropriations. If we move to the next slide. SB 250 by Ochoa Ba is a simple bill that will help Medi-Cal enrollees search for skilled nursing facilities that are covered by their plan. Under some circumstances, a skilled nursing facility can be the best option for people living with Alzheimer's. It can be difficult to navigate the available options when designing a care plan that is right for individuals living with dementia. This bill was placed on the consent calendar in Senate Health. It has been placed on the suspense file in Senate Appropriations thereafter. If we can move to the next slide, which is my last one. This is another simple bill that was on the consent calendar, but it is an Assembly Bill 403 by Assemblymember Ortega. It requires data collection for the community health worker benefit offered to Medi-Cal enrollees. Community health workers, or CHWs, serve as a liaison between health, social services, and the community. CHWs often serve as cultural and language interpreters, which helps individuals navigate the healthcare system, communicate with providers, and advocate for their specialized care needs. CHWs have an intimate understanding of the communities that they serve and are trusted care team members. CHWs can assist individuals with Alzheimer's and other forms of dementia by providing a keen understanding of the cultural values to plan daily activities, assist with communication, and provide guidance for end-of-life wishes as well. As I mentioned, it was on the consent calendar in Assembly Health Committee, and it has been placed on the suspense file in Assembly Appropriations. And that does conclude my presentation.
Thank you both for the legislative update. Now it's time for us to make any comments or ask any questions for them. I think I saw Dr. Mobley's. Yeah, Dr. Mobley.
Yeah, thank you so much. It's for Barbara. Barbara, I see a lot of people now becoming quite aware of the very real likelihood that their financial security is under threat. The cabinet meeting yesterday suggesting that we'll have to go from $30 to $2 was a gross example of the cruelty that's attending these really incredibly aggressive, potentially injurious activities. While I see people concerned about their bottom line, I don't know that people really understand that basically degrading the activities in the FDA, the NIH, are going to compromise their chance to have a therapy that works for them or their loved one with dementia. I'm afraid there's so much chaos that some of the things that really, really matter, and this really, really matters, are being lost in the dust, in the cloud. And I'm wondering, how can this committee or the state, how can we make it more evident to the average American that their dementia care is in deep trouble because of the changes that we're seeing being made by the administration?
Yeah, I mean, it's a great question. I think when it comes to people who sit in official places, state government, county government, it's hard for them. In a lot of cases, their hands are tied. There are certain things they can't say and certain ways they can't use themselves. So what I think that does to those of us like Alzheimer's Los Angeles and other health coalitions that have formed to try to push back on some of this is we need to push more messaging out there. And then people, for example, who get our emails then need to share that more. You know, if you are on social media, you know, post it to, you know, the platforms that you're on, talk about it with your neighbors. Because I think that you're right. It is such an avalanche of information. And it's depending on whatever the story is that maybe that particular media outlet has chosen to focus on, there's a whole bunch that's being left unsaid. And so, I don't know if there's anything this committee as a committee can do. Maybe this is a question of some of the staff, that support this committee, like what are the limitations of the advocacy messaging we can put out there? So then it falls to each of us in our own individual roles to make sure that we're educated, which is why I wanted to share that information today, because I want you guys all to have it and then talk about it with your circles.
Yeah, I think when I think we really ought to. I mean, this is not a political message. The message we're delivering is members of a committee that we're really worried that what's going on at the level of federal funding could compromise significantly the well-being of caregivers and those they care for. So, I mean, I think we should carry this forward as a very powerful statement. And it really, it makes sense for us to speak to this in California. And then, Barbara, I'm just thinking nationally, nothing tells a story better than the story.
Mm-hmm.
And I'm just thinking maybe the Alzheimer's Association could be very out there and aggressive in telling stories of real people who got care, people who didn't get care, and maybe people who will never get care because of these intrusions on what was a very, very good process before this. So again, I don't have a solution, Win or Barbara, but I think we can't be silent. This cannot be a time for us to pretend it's business as usual, because it's everything but that.
Yeah, I agree with you completely. And story banking is happening. My organization is doing it. We are sharing it with national partners because I could not agree with you more. Facts are fun. I like them, but elected officials and the general public are moved emotionally by a story. And so it is a really powerful advocacy tool.
Thank you, Dr. Mobley and Barbara. Yeah, we definitely need to make sure that our voices are heard for the people who can't speak for themselves. I think not only should we be sharing our stories, but all these programs that have been developed and have been found to be helpful, we should share that there has been some results with all these things that we've try to do and that we should continue to do or even expand. Anyone else? Anyone in the room? I can't really see the folks in the conference room there. No? Okay. All right. Should we, I think we're gonna open it up for public comments, is that right? Let me look at my
Yes, you are
yes.
correct.
Okay.
Hi, good afternoon, everyone. This is our second public comment period of the agenda. And we've heard quite a lot today. If you'd like to make a comment and you are in the room, raise your hand and one of the staff will call on you. Online, our attendees online, you have a raised hand icon via the Zoom webinar functions. Please feel free to click on that. And if you are calling in, it would be *9 that would also raise your hand. So happy to take your comment now. Do know that you can also submit a written comment in the Q&A. We've had a couple of those today. Also, at any time, you can email our Engage email box, which we do monitor all days of the week. I'm sorry, 5 days a week during business hours. Engage, ENGAGE, at aging.ca.gov. Well, again, anytime you would like to email us, feel free to do so. Engage, ENGAGE, at aging, ANGING.ca.gov. And Dr. Canio, Carlos,
I think we
do
can
not seem to have any public comments at this time.
Okay. I think it's time for us to make our final recommendations for the secretary. As we think through final recommendations, we encourage us to stay grounded in these outcomes and how they can connect to the broader priorities. What stood out to you as the most impactful idea today? Or do we need further input?
I think it might be Dr. Mobley's comment about, you know, underscoring the potential damage that the actions taken at the federal level would have so broadly here in California.
Definitely. Thank you.
You should just go listen to the recording. I felt like you said it just perfectly, Dr. Mobley.
He did.
Just transcribe that.
I didn't even want to repeat it to butcher it.
I know.
So Ranjana, please go back to that. And yeah, he said it perfectly. I think this morning too, there were some great comments about how can we share all of these great resources we have, right? How can we also update these resources that are being implemented? I know there were some ideas, or that I guess we heard that they are auditing them quarterly and also making sure that perhaps leveraging AI to ensure updates for these things. And then Dr. Kazi talked about, trying to figure out how to meet demand for these resources that are available as we, yes, we do have these resources, but once we know people know about these, we might need more. And how are we going to then address that? Yeah, just making sure that the information is accessible to all. Go ahead, Barbara.
Could we maybe, when we're talking about the conversation we had this morning about no wrong door, could we put in a sentence there, maybe that something like, despite, challenges that funding decisions or like, we don't want to see that work slowed down or derailed by some other decisions that are made funding wise, at the federal or the state level. That it's so important that this No Wrong Door initiative move forward robustly.
Can agree more. Yes. Friend Janice writing notes, so she got that. Anyone else? And just know that there are still a lot of information that we received today. It's good to still share those resources that are available, that what we have. I know Dr. Gravano is leading some of that work with the caregiver training. Once those are available, I think all of us should be aware of those and make sure that we are sharing them to everyone. Carlos?
I think we need to ask, where do we need to further input or engagement before finalizing recommendations? Anybody has any input? I really like what Dr. Mobley said. Because it's current and it's important to recognize that. And
do you think we could, Carlos or Wynn, do you think that we could ask for an opportunity to speak to the Senate and the Assembly? I mean, why can't Barbara just go up there and make our case?
Susan?
Well, if it's at the federal level, though, that's that's where I think our first challenge is.
Yeah, I mean, I think so.
I can add to that, what we heard, the former, this is just one perspective, but Allison Barkoff, who led the Administration for Community Living for many years, recently spoke at the American Society on Aging conference, and she has encouraged us to work in unison as a coalition. And it's absolutely, Dr. Mobley, meetings with U.S. senators and U.S. members of Congress. And we're urging people to go in coalitions. So instead of a small subset of people talking about Alzheimer's and a small group talking about nutrition, to work with all of your partners at the local and community level to really show this ecosystem that is built up around people and the interdependencies among many federal departments and agencies.
I'd also like to add that as a volunteer advocate, we working with the Alzheimer's Impact Movement, we get regular updates on how to approach our members of Congress, and we get prompted often to send them a message, asking them to look at different bills or funding requests. But I think it's also important that we maybe take initiative on our own to reach out to them on different occasions to say, hey, we don't like what's going on at the federal level, and we need to have certain things highlighted. I think it's important as a community, as citizens, we voice ourselves. And it's important that a lot of the things that are happening now is going to impact us at the state level. So, if anybody doesn't have anything else, I would like to thank you for your thoughtful input and commitment to this work. Your voices are critical in shaping strategies that are both meaningful and actionable. We'll send these recommendations and items to the California Health Secretary and keep on pushing forward.
Thank you.
Thank you.
Thank you, Carlos and Wynn. Thank you for leading us.
All right. Just a few more things before we finish. Just reminders, our next meeting is August 7th, and I think November 6th is where we are highly recommending everyone to maybe gather in Sacramento, but we obviously will have the hybrid or the Zoom version for those folks who choose to do so. Then go ahead to the next slide. I think that is it, right? Yeah, so just thank you everyone for your thoughtful participation and insights today. It's been incredibly valuable to engage in such a collaborative space where systems of care are not just acknowledged, but actively explored. And as we reflect on today's discussion, I want to especially lift the importance of continuing to center the lived experience of individuals living with Alzheimer's and related conditions, along with their caregivers, and making sure that we are providing that voice for them. So, Carlos, any closing remarks?
Just looking ahead, I'm excited about the opportunities we've identified today to strengthen partnerships across aging and beyond, whether we're talking about service coordination, workforce development, or policy reform. It's clear that our collective work is not only necessary, but also urgent.
All right.
Thank you everybody for participating today and adding input and feedback. We really appreciate it.
Thank you, everyone. See you in August.
Thank you.
Thank you, guys.
Thank you. Bye.
You.
Thank you.
Good day.